Everybody, I thought I'd share something that might be more routine than the cases I've shared in the past. So this is a crown restoration scan. So we use iTero to scan all of our crowns, bridges, veneers, inlays, onlays, which I don't do very much anymore, to be honest, inlays and onlays, dentures, partials, Invisalign. Anyway, I wanted to show you a simple case of a crown here on tooth number 2. So you can see this patient's had some crowns in the past. This tooth needed a crown because of recurrent tooth decay and fracturing. So let's turn off the lower. We'll zoom in here. So looking at this 3D rendering, you can see it looks like a decent prep. We have a nice margin of enamel working its way all the way around. I do my best where possible to leave some enamel when I'm prepping a tooth because enamel has a higher bond strength than dentin does to resins. So where possible, I want to leave enamel. However, most of my crown preps will go all the way down to the gingiva. I'm not going to intentionally remove enamel if enamel is remaining. I know some people will do that. I'm not faulting that. It's just not what I normally do. So you can see the 3D rendering's a little bit pixelated, not really clear. Let's go ahead and turn on the magnifier or the spyglass here and get an actual picture. So there we can see two views. We can see the infrared view there on the top and the actual view here on the bottom. You can see some lens artifact there, whether it's some stuff on the lens or what have you. Then we also have the infrared view. So if I turn this brightness up, sometimes that'll help to see a little bit better. Anyway, so the crown prep's decent. One of the things I always shoot for is nice smooth transitions. Once in a while I end up with a little rough ledge there. I tend to use telescopes, these 10x telescopes, so I cheat quite a bit. If you don't have a set of telescopes, I would encourage you to look at something. They do help make the job a little bit easier, although I'm not saying you can't do a great job without them. I know a lot of docs, one of my previous partners in particular that practices in St. Peter's, that does a great job without telescopes. Maybe it's just a crutch that I need to do to do what I need to do. Anyway, so the prep is decent. I'd give it a A minus. Could be more perfect, especially around the margins. That little kind of a rough ledge there isn't perfectly ideal. But in the end, as long as we have a good long-term outcome, a good clinical outcome, that's what matters. One thing I'll draw your attention to here, let's turn off the spyglass, is let's look at the interocclusal clearance. So always remember, all you dentists out there, that clearance does not equal reduction. We need to do adequate reduction, and then we'll have the correct amount of clearance. We can't just look for clearance, and I know that kind of is a circular logic pattern, but make sure you do appropriate reduction, which will lead to the clearance that you need. So here you can see it looks like we've got ample space. I don't know exactly what that measurement is, but 1.5 millimeters or so. Adequate space for zirconium oxide, potentially for lithium disilicate or something like that, a glass. The problem with lithium disilicate in this indication is usually the manufacturers are calling for 2 millimeters over the functional cusps. So this could be something that's under-reduced and could yield a failure down the road. So double check your reduction, always, always, always. And when we go into design, you can actually measure that space. But be aware, what we're measuring is the distance from one tooth structure to the opposing tooth structure. That's the raw distance, the gross distance, if you will. Don't forget, when you design a restoration, it's going to build in a cement spacer. And so that thickness of the restoration now becomes less than the space that's there. So be cautious as you're designing, whether you're designing them in-house, like we do here for most of our crowns, or whether you're sending them to the lab. You have to have adequate reduction to allow for the appropriate amount of space for the restorative material to be used. Otherwise, you're going to end up with a lab tech that calls you, hey, do you want me to spot the opposing so you can adjust, or what do you want to do? And a lot of times they'll just get to the point where they're doing what they think you want to do, which might ultimately yield a restoration that's not ideal. So double check your reduction, make sure your clearance is appropriate for the material you're using, and make sure you know what your cement spacer is that's built into the space around the restoration, or around the tooth where the restoration fits, because all of the digital design processes will have a parameter that you can adjust so that you can either increase or decrease that cement spacer thickness. So be cautious there. Let me recap that real quick. Just because I have what looks like 1.5 millimeters, after the cement spacer calculation, it may only be 1.25 millimeters, or less or more. It just depends on what that cement spacer adjustment is in the design process. So confirm you have adequate reduction, which will translate to the appropriate clearance for the material that you're using. And then when you design, you want to make sure you get a quadrant, at least all the posterior teeth, so you can see where those cusps are. Because if you design a second molar with a palatal cusp that actually is going to act as interference, you're going to set yourself up for an unhappy patient, lots of pain and discomfort. So hopefully that's been helpful. Just, and a final couple of thoughts on this. As I've told associates and partners and those that I've taught and trained and lectured to in the past, that we always shoot for perfection, for clinical perfection, clinical idealism. We're looking for ideal, smooth, rounded edges, margins, and every time we prep and do anything, we should be targeting perfection. However, there is a difference between clinically acceptable and perfection. So one of the things we dentists tend to do, as many people do, it's not exclusive to dentists, is we hold ourselves to too high of a standard. Now, I'm not saying we shouldn't have a minimum standard that matches appropriate clinical protocols that yield good long-term outcomes. I'm saying we should not expect perfection from ourselves all day, every day. It's important that we have a little bit of breathing room, but it has to be clinically acceptable. Let me reinforce that. Even though it doesn't have to be perfect, it has to be good enough to be clinically acceptable and at or above the standard of care. So anyway, thanks for watching. If you have any questions, send me a message. Thanks. Bye.